Good day, everybody. This is Lorraine Greaves, and Nancy Poole will be joining me to co-present today. And we're happy also to have Christine Federley on the panel. And she'll be presenting at the very end, talking specifically about some resources available to everybody on this topic, tobacco use and reproductive health, an update. What we're going to be discussing today are the results of a project we've been doing over the past year that has taken a close look at Chapter 20 on reproductive health in the Tobacco-Free Futures Guideline and revised it. Also taken a look to create new resources, including a help guide and coming later, an infographic. So we've got quite a bit to talk about today. Nancy and I will run through some of the things that we found during the update. And I really want to focus on what's new and different. So welcome, everybody. There's the picture of me at the top and Nancy at the bottom. And I also want to acknowledge Natalie Hemsing, our research associate at the Center of Excellence for Women's Health, who has also done a huge amount of work on the background to this document and to this revision. And on the right, you'll just see some of the other resources we have on offer at the BC Center of Excellence for Women's Health on this topic. So this project, as I said, revised the TFF guideline and helped create the help guide and also this infographic. And you can see this picture of one side of the infographic here. And it basically is a short document that will illustrate some of the key points that I'll be discussing today and that Nancy will be discussing, and will help you to really have a ready guide at your fingertips that you can use either with your colleagues or with patients. So what's new? In this revision, there are 4 principles that we introduced, and I'll be talking about each of them in turn. And these principles are meant to underpin everything that you do when dealing with women or girls, pregnant or not. And I say that because we're taking a much wider approach in this particular revision of the guideline. It's a pre- and interconception care approach. And what this means is that we do not focus entirely on the period of pregnancy when talking about tobacco use. We do not focus entirely on fetus centricity or fetal health, but rather we take a much broader approach to the entire reproductive cycle for women and for men, and understand tobacco use in a much broader way. We also quite specifically talk about tobacco use in pregnancy as a youth issue. And despite the fact, as you'll hear, there's not a whole lot of research on this piece, it's clear from the statistics that this is perhaps a shift in thinking we all need to make when intervening. And certainly, we're highlighting the notion of addressing spontaneous quitting and supporting it. Even though spontaneous quitting has always been there early in pregnancy, often before the first prenatal visit, it has not really been addressed and supported in a conscientious or conscious way. We talk about the idea that we need to involve men and thinking about male reproductive health in this approach, and we have adapted the 5 A's. So this standard approach of the 5 A's has been adapted to incorporate some of these principles. And absolutely, last but not least, it's really important for all of us to be thinking about new nicotine delivery mechanisms and cannabis as either mutually used with tobacco or used instead of tobacco, and our need to expand our thinking and start asking about these matters as well. So, Nancy?
Yeah, here's what we're going to cover this morning, which sort of parallels the work we did on the tobacco-free guidelines. talk very briefly about prevalence and health impacts, and spend the majority of the time this morning talking about interventions and particular groups of people that we have focused on a bit differently in this chapter than previously. And then, you know, to provide a bit of a summary and opportunity for you to ask questions. Now, as we go along, you can type in questions for us to respond to at the end. In the bottom right-hand corner there, you'll see the Q&A section. So please, as we go along, think about entering questions as we go. And just so that you know as well, we are recording this webinar, and we will make the slides and the webinar recording available on the Center of Excellence for Women's Health website, and eventually on the Alberta Health Services website as well. So here's the prevalence section, just a quick look to for us to be able to see, you know, progress has definitely been made in terms of current smoking in Canada. But, you know, our job is in no way done. And really concerning, I think, is this sort of equivalent levels of smoking amongst girls and boys, which is, you know, I think a major concern in terms of what we know about the health impacts. In pregnancy, we're seeing declining rates, but in Canada overall, but in Alberta, still, you know, almost 12% of women smoking during pregnancy, and a really wide variation in prevalence across the Alberta Health Services zones. And interestingly enough, the highest rate being in the central zone. And here's a picture that is in the chapter of maternal smoking by zone of residence over time, so that you can see, you know, significant changes since 2004, but also still lots of work to be done. And I think it's really interesting, this issue of prevalence in terms of adolescence, and that is, you know, and Mary and Lorraine mentioned that we are focusing on in this chapter much more than previously, and you can see why here with the smoking prevalence for underage 20 pregnant girls being close to 40%, and of real concern. In the health impacts, one of the things we've been able to do is to put some of the health impacts, which I'm sure all of you are well aware of, into the infographic in some new ways that may be helpful when discussing tobacco use with women. There's lots of background to this in the chapter itself. You know, how lung health, breast cancer, all these areas of women's health are affected by tobacco use. And really, you know, great information for discussing with women in both the health guide and the chapter. And here's a summary of some of the health effects written out, so you can see them as an appendix to the health guide. So just so you know that this kind of information will be very much at your fingertips.
So this is Lorraine again. I'm just going to be talking a little bit about some of the principles I mentioned earlier and how important we feel they are to underpin all of the approaches that we might choose to take with women and girls. And then I'm going to be talking about some key considerations and various forms of interventions, intensive, pharmacological, brief, and preconception. So in this section, I'm just going to very briefly refer to what is written out in the Chapter 20 in much more detail with all of the references included in that document, and which is also covered in the help guide in a different way. So here are the key principles. This is new to Chapter 20 and to the infographic in the help guide. But it really is important, I think, to be very clear about what we now know are some of the better practices in approaching women around the issue of tobacco use and reproductive health. And certainly the business about being woman-centered is really critically important. There has, as you all know, been a long history of focusing just on fetal health for the purposes of discussing tobacco use and reproduction. And we're attempting to really broaden our lens here to talk about women's health and her context, what kind of situation she may be living in or experiencing, both before, during, and after pregnancy. And in this way, it's felt that this is one way to really try and deal with relapse prevention as well, by perhaps generating motivation for being tobacco-free that is focused on a woman's own health and that will carry her through all of those phases of her reproductive life. The second one is the explicit introduction of harm reduction. And this really is connected in a sense that it respects a woman's right to decide and to identify what steps she can take in the context of her situation, some of which might not be quitting, they may be reducing, and if not either reducing or quitting tobacco use, it might be reducing the harms of tobacco use and exposure to herself and to her existing children. It might be by generating approaches that improve her health in other ways, such as improving nutrition. Third is the notion of being trauma-informed. And I'm sure a lot of you have heard about this approach, but what it really refers to is quite simple. It's about being universally sensitive to the effects of trauma and violence on women's lives and its impact on tobacco use. We now know that there is a connection between trauma and violence and tobacco use, and you've probably observed that in your own practices. But what this means is that you don't need to generate disclosures to be trauma-informed. You just need to assume that you require that sensitivity and understanding of those effects as you address tobacco. And last but not least at all is the notion of being equity-informed. And this is recognizing the social, cultural, and economic pressures and factors that affect women's lives and affect what they need. And this might be because they are of a particular socioeconomic group. It may be that they have pressures, therefore, that are financial that prevent them from doing certain sorts of things to improve their health. It could mean, in the case of a particular ethnic group or in case of Indigenous girls and women, particular cultural approaches need to be taken as well. So those are the 4 principles. This is how they look on the infographic. And it just really tries to briefly remind you that these are the kinds of things to be thinking about as we try and really reduce the rates of smoking during pregnancy for sure, but also the rates of smoking among girls and women in general. So here's a key consideration that I alluded to before, and that is it really is important to consciously address spontaneous quitting. Many women quit smoking before their first prenatal visit. And the research is quite hazy on how many, but it could be anywhere between 25 and 50%. And these are women that previously have been invisible to the practitioner often. Either they haven't been asked about that or they are reluctant to talk about that. But basically, this is something that we're now suggesting be asked about. And the reason is so you can support that woman to prevent relapse both during pregnancy and postpartum, because as we've known for a very long time, the postpartum relapse rates are extraordinarily high among women who quit during pregnancy. Indeed, a phenomenon called temporary abstinence is a common thing. And therefore, for both spontaneous quitters and for women who you know are quitting or reducing during pregnancy, it's essential to start that support and feedback during pregnancy as well as postpartum. And of course, as mentioned, the focus on the women's health needs to become the motivation. And really is about addressing the long-term motivation for quitting. For women's health, for creating smoke-free homes, and for general longevity. Another key consideration is about context as well, and that is we know very clearly that the partner smoking status and the smoking in the household, whether it's more than the partner, is kind of really critically important for addressing smoking during pregnancy and postpartum in general. And it's very difficult or more difficult to reduce or quit when surrounded by smokers. So it's very important for all of us to really get a handle on what is the social context in the relationship and in the household around quitting and reducing. And be aware this is not always one way. This can be that women quit or reduce or even non-smokers during these periods, and it could be that partners and household members are smokers, and there could be pressure in that direction. This little booklet here is an interesting resource for dealing with this kind of dynamic and other dynamics during pregnancy and postpartum between men and women in particular, to talk about what can happen when there are pressures to reduce or quit on either partner. So having stated the principles and the key considerations, just want to talk a little bit about some of the approaches. Intensive counseling is one that we do write about in the guideline in Chapter 20. And it's also something we've written about extensively in our books, Expecting to Quit. 2 editions of that now exist. And this is really the kind of approach where there is multi-components involved, where there's health education, feedback, ongoing social support, sometimes group work, certainly lots of tracking of women. And so this is perhaps kind of the Cadillac of approaches, which is not to say that some of the approaches I'm about to talk about that are more brief or that include drug treatment are not worthwhile. They certainly are. But women, it turns out, benefit more or maybe need more intensive counseling than men do, as far as we can tell. And that's primarily because the social support elements appear to be very beneficial to women. And it helps with raising the rates of quitting successfully, especially during pregnancy, but also in general. And there are some obviously specific issues that are connected to women and women's health that are both sex-specific and gender-specific. Certainly concerns over weight gain and also emotional states are different with women compared to men. The pharmacology issue. There are certainly overall, when we look at all women and girls, not just pregnant women and pregnant girls, there are sex differences in the effectiveness of various NRT therapies and also varenicline and bupropion. But it's still being recommended, certainly, as a pharmacological support for pregnant and postpartum women once first line of intensive support or any other behavioral support, such as counseling, motivational interviewing, it has been tried. And so NRT is considered a second choice or a second line option. And this is because, similar to the last edition of Chapter 20 Guideline, there is still inconclusive evidence about the effectiveness of some of these drugs and the safety of some of these drugs. Varenicline is a good example, and bupropion is really third line because these guidelines recommend avoiding them or considering them only as a last resort. And it was quite interesting for us to find that there's contradictory guideline. There are contradictory guidelines around these two drugs, both within Canada, but certainly between Canada and other countries. But the majority of countries, including the UK, the US, Australia, and New Zealand, all suggest no use of varenicline or bupropion during pregnancy. So we're certainly going with that more conservative and cautious approach. And, you know, it's clear that this issue still requires much more research to come up with some definitive statements about just exactly when and how NRTs should be used. The brief interventions, these are for all women and girls. In the case of all women and girls, often involve conversations that are strengths-based, conversations that are woman-centered and trauma-informed, as mentioned earlier, conversations that use motivational interviewing, confidence building. And in this particular resource that's pictured here, which is free for all of you, there are actually scripts for what practitioners can say and how to have this conversation with women and girls over a period of time. And obviously this can be done at any stage in reproductive life and can certainly start at any age, no matter what the reproductive decisions are of the girl or woman.
And
when it comes to,
and you know, Lorraine, you know, when we were working on the Liberation Guide was when we first began to think through the application of these principles of brief intervention with all women, that we have been able to further evidence and look at for the Alberta Health Services work here, and to really think through how do we bring these principles into traditional evidence tobacco interventions and guidance like the 5 A's. And this is a picture here from the Chapter 20 that really shows along the right-hand side ways in which these principles can be incorporated into each of the ask, advise, assist stages of the 5 A's with pregnant women. And I think from that point of view, you know, for for people who are used to doing tobacco interventions using the 5 A's, this is extremely helpful kind of algorithm to have with the additional ideas about how to bring women-centered approaches into advise, how to bring harm reduction-oriented approaches into assisting, et cetera. So I think I think this is a really great addition to the work that's gone previously. And, you know, just as a reminder that these are the overall guidelines from Cannabis, and they are also repeated in the Chapter 20 and outline exactly what you've just been speaking to, Lorraine, around tobacco cessation being encouraged, smoke-free homes encouraged, counseling recommended as first line, then thinking through nicotine replacement and really focusing on partners as well. I think that, you know, the move to preconception focus is really an interesting one, and one we've been doing a lot of thinking about as we've worked on prevention of fetal alcohol spectrum disorder and work on cannabis and other substances that are legal or soon to be legal. And I think it's, you know, it's a really exciting way for us to start to think about how we can prepare people for tobacco cessation long before pregnancy actually happens, and really, you know, bringing partners in much more than ever before to be thinking about it and creating life plans that include being tobacco-free. And I think, you know, there's lots more attention being brought in public awareness to the importance of these preconception health behaviors of all kinds, and integrating, you know, nutrition and all the things that are important to be aware of in terms of preparing for being pregnant. So I think this is really giving us lots more territory to be considering about how best to do and who best can be having these preconception interventions, and also not losing the thread between pregnancies, the interconception period, and continuing to support women who use tobacco in that period to think about how, you know, using the more intensive interventions you've mentioned.
Yeah, it's worth remembering in the context of this that almost half, about 48% of pregnancies are unplanned. So it's another really good reason for practitioners to be thinking all of the time about tobacco use and other kinds of drug and alcohol use as well as a topic of discussion.
And, you know, I think that it's very exciting to think about how we can involve men more in the preconception work, boys and men, and girls and women in thinking through how best they can be healthy in order to have the healthiest pregnancy possible. And I think it's just really interesting, some of the things we're beginning to learn about men's role in preconception, in tobacco and health issues, and how we are starting to see some of these child development outcomes that are directly related to men's role in pregnancies as well. And so really emphasizing that quitting tobacco and tobacco-like products before trying to conceive is best for both men and women.
So the last section is just going to run through a few what we call tailored interventions, just trying to bring the principles to life. It means that these guidelines suggest you constantly think about the woman's context, her social system, the amount of support available, perhaps think about harm reduction in all of these contexts, and certainly think about trauma-informed approaches and equity approaches. So that's the reason, once we think about those principles, that's the reason why we're also encouraging tailored approaches. So here's one, and there could be many, but here's one that we're highlighting, and that is the notion of breastfeeding. And the advice is to continue breastfeeding while women are attempting to quit or reduce. It is true that nicotine passes through to the breast milk, but the benefits of breastfeeding are deemed to outweigh this impact. So one harm reduction approach that we do discuss in the guideline is timing tobacco use appropriately so that the nicotine is more cleared from the system prior to the next feeding. So there's just one example of using a harm reduction approach at the same time trying to maintain breastfeeding as a better practice for all mothers. Mothers and fathers, you know, the whole business here of second and third hand smoke, and certainly the introduction of many other kinds of nicotine delivery devices, not to mention the introduction of cannabis in many forms, including smoke. There are lots of things to think about here with respect to exposure to second and third hand smoke. And this is not just about children, though it's certainly a main motivation, but it's also about women and men as well. Decreasing the exposure of secondhand smoke is always a good thing. There are health effects for non-smokers and smokers to secondhand smoke. So on the right, you'll just see there's just a diagram that we took out of the worksheet attached to the help guide, which may help when talking with either patients or clients on a one-to-one basis, or in a small group. Could be used with a group if you have that opportunity, where you can actually talk about some of the strategies that one might use, in this case, to reduce second and third hand smoke, and work through those things with people to produce some discussion points and some actions. Another one, going back to one of our main points actually, that when we step back and look at this issue, we realize it's really a young person's issue primarily. A lot of the reduction in smoking during pregnancy and postpartum has taken place in women over 25 years old. So the group of women who are pregnant and postpartum who are under 25 are often the ones smoking at those very high rates that we showed you at the outset. So our argument is, despite the fact that there's a dearth of research on how to best intervene with pregnant adolescents, we really all need to be thinking in this frame as we approach our work, and thinking about what might tailor this approach better with this particular age group. And certainly when we think about the social issues, the issues of peer and partner support loom large. A harm reduction approach we think might work, but certainly the social issues attached to this age group are many, and you can see some of them listed here. Identity issues, as it's the phase of identity formation, whether it's gender or culture, sexuality, dating violence as a form of violence and trauma, child abuse as a form of trauma, and certainly the issues of depression, self-harm, body image, all of those kinds of things get connected, especially in girls. And we have done some work with girls groups in Canada talking about some of these issues, and certainly they're affirming to us in those projects the links between depression and smoking, depression and alcohol use, and so on. So we do think there's a very rich area here for all of us to start thinking about more clearly as a youth issue. What is it that might be different, and what is it that we might need to either create in terms of programming or create in terms of research questions going forward. Certainly, for those of you who follow the trends and statistics, you'll know that Indigenous women and girls also have higher rates of smoking than non-Indigenous in Canada, and that those rates of smoking increased at a later stage. So it may be that we need to take a very different approach here in terms of tailoring as well. And certainly some work has been done in this zone, but I think a lot more needs to be done that really looks at, again, the context, that looks at the community and cultural supports that may or may not be available, that understands trauma in an Indigenous context, and invokes all of those pieces of knowledge to create different forms of interventions and different kinds of materials. So those are just some ways that tailoring can be done. And certainly there are many others. I know there has been a lot of work done in Alberta and elsewhere on low SES women as well, and how we might best frame interventions there. There's no shortage of attempts, but I do think in this guideline, we're trying to get all of you to think more consciously about bringing in those differences to your work. And certainly, last but not least, as we've mentioned more than once, the issue of pregnancy and reproduction in cannabis use is all of a sudden, because of the looming legalization in Canada, a very hot topic. And we therefore created a help guide module on this. We've also worked on a different project that was created in Ontario looking at the current evidence on this. And the bottom line is that we have a lot of research missing still on this question. We don't really know fully what the long-term effects are. And so caution is being advised at this stage to both pregnant girls and women to understand what the existing research might say, and to understand most importantly that we don't have definitive answers yet on what exactly the long-term effects are of using cannabis on either young people or on the fetus or on an infant or a developing child. Obviously, this also addresses the notion of parenting, mothering and fathering using cannabis as well, and what that might do to your parenting style. So on this slide alone, as you can gather, there's lots to think about, lots of work to do to integrate this kind of information in with other kinds of information on tobacco or on alcohol, especially, again, for young people, girls and women and young boys and men who may be considering or may be involved in reproduction. So there's really quite a lot to think about here. So we
hope you haven't made your head hurt with all this new critical thinking in this, you know, age-old topic of tobacco and reproduction. And we just wanted to provide 3 slides here that kind of sums it up a little bit of what's in the chapter and the help guide and the infographic. So we, you know, have made some summary recommendations which you'll recognize about all women and girls of reproductive age, to be thinking about these principles of women-centered, harm-reducing, trauma-informed, and equity-informed as we're delivering tobacco interventions of all kinds, whether they're brief or more intensive. To really think about the preconception period and what our general advice for girls and women of reproductive age need to be, and to think about, you know, the 5 A's, both that are relevant to all women and to adolescents, and integrating those in a way that supports those girls and women who are not pregnant or breastfeeding, and using those in that way that includes the principles, and really offering pharmacological support and behavioral support alongside of pharmacotherapy to both women of reproductive age. When it comes to pregnant and postpartum women, really thinking about behavioral cessation support using the tailored 5 A's, that's first-line treatment, using motivational interviewing, as we know well, to build upon the strengths of the woman to reduce and quit, really making a women-centered approach through that evidence-based practice. Offering NRT only when behavioral cessation support counseling has failed, and really thinking through, how to provide an informed discussion with patients regarding risks and benefits. And considering the use of low-dose intermittent delivery NRTs as opposed to the continuous dosing of the patch for pregnant and postpartum women. And medications, as Lorraine mentioned, only considered after behavioral interventions and NRT have failed as a very last resort, and encouraging breastfeeding, even if using tobacco or NRT, and really offering ideas about how to make that as safe as possible. And then, summing up, really trying to emphasize the pregnant and postpartum adolescent interventions to, use the 5 A's for pregnant women and adolescents. Think about, what pharmacological supports are needed that are similar to the ones mentioned for pregnant and postpartum women overall. And really, thinking through much more than we have about how best to discuss risks and benefits of all treatment options, and providing choice and agency and thoughtfulness in the considerations and principles and practices we've described today. So Christine, we'll turn to you maybe here to talk a little bit about what resources are available online.
Great, thank you everybody. I'll just walk through very quickly what we do have in place for everybody to access and what is coming soon. And these were hyperlinks on this PowerPoint. I'm not certain if people are able to access a slide deck after this event. Are they able to, Nancy?
Yes.
Or is it just a recording? There's a slide deck as well?
Yeah.
Okay, great. So the slide deck, you should be able to left-click on the resource link, for example, and then it would pop open. You can open the hyperlink for each of these. So I've embedded that just to make it easy for everybody in the future if they want to refer back to any of these locations for resources. So starting on this page, just to review what we have for health providers. So on the albertaquits.ca website, which hopefully many of you are familiar with, we do offer the Alberta Quits Learning Series. So there is quite a series of professional training for learning cessation skills and preparing you to be able to do intervention well with clients and patients. And we do want to just make a note to everyone that we do have the Certified Tobacco Educator Prerequisite trainings available through Alberta Health Services. There's 5 trainings that are available through our website. If you go to that location, you can look at all the details on that opportunity. The first resource I want to refer you to is the Tobacco-Free Futures Reproductive Years Guideline, and it's been commented on here a number of times in this presentation. So that resource was updated with our host today, and that has been located online now for, I would say, about a good month and a half. So if you've seen the Reproductive Years Guideline prior to that, you would have been looking at the first version, and this is a very much improved version. So I encourage you to go and look at that new copy and update any of your paper files that you may have if you've printed it. The one at the bottom there, you can see it says coming soon, and that's the baby steps help guide that you've heard us referring to today. So the help guide is, although it will seem kind of lofty when you open it up, it's about a 180-page resource. The resource is actually got 3 chapters and then quite an extensive list of discussion topics at the end, which are optional as to which ones might apply or be most appropriate for the client or patient you're working with. The Baby Steps Help Guide, we are hoping will be available the end of the summer, so probably sometime in August. And the current status on it is it's just nearing the completion of the work on it by an editor to review and correct anything with editing. And the next step will be going into the graphic designer's hands and having him do all the beautification to it and making sure it works online properly. And then we'll be loading it up. So we're getting there, but it certainly is a little bit of work to be done to it yet before it'll be ready. Did you want to click there? So the other thing I just wanted to note is probably what most commonly people think of when they think of Alberta Quit's website is all the resources that are available for the public, for people that are concerned about someone who uses or is wanting to try to reduce or quit themselves. So on the Alberta Quit's website, there's certainly lots of links, and there are a few things there that they might find actually new and interesting. And the key one is we've updated the Baby Steps. It's a cessation booklet that people might have seen over the past few years. There's a paper resource that could be ordered by health professionals and distributed out through patients and clients. And we've actually given it a complete overhaul and update, and that is going to be an e-resource that will be available on the website in the public section. So if you were to go to Alberta Quits and you look under the tab Quitting Smoking, you'll see a little tile there for download e-booklets, and this is going to be a brand new e-booklet in that location. It should be up by end of today. I was just, as we're talking through this, I've been corresponding on the side, and it sounds like he thought it'd be up by noon, but give or take, we're going to say today it's going to be up for you. So feel free to check that out. It has a new title, so it's called Let's Talk About Tobacco, a guide to help you stop use and exposure during and after pregnancy. And just a note that we also will be uploading an e-booklet for public in general who want to make an attempt to quit. So there's going to be 2 booklets, 2 cessation booklets in that series that will be available there. Outside of that, there's an immense amount of resources for health providers, and I really encourage, if you haven't ever looked at the Alberta Quits website, if you check under the tab at the top called Helping Others, you can access many downloadable resources. The Tobacco Cessation Toolkit is available there. We also have an online catalog, which is wonderful for folks, particularly in Alberta, where you can order resources for free. So there's an endless amount of supports and information that's accessible to people there, and I encourage you to take a peek through all of that. And that, I think, in a nutshell, it covers the resources we have available to you, and I'll pass it back to you, Nancy.
Yeah, and of course, the resources we've referred to that the Center of Excellence has worked on over the years that, kind of form the background of our work with Alberta Health Services are still available on our website and on a particular special website that has the Expecting to Quit document as well, and digital narratives and all manner of things. So lots of resources available to you. And we just want to mention,
Nancy, I wouldn't mind
if you could go
I could
one
just
more.
mention that.
Yeah.
Sorry.
We're hoping to share the infographic with you all when the health guide is ready. Is that right, Christine? That you were going to mail out the infographic when the health guide is ready?
Yeah, we're going to send out the infographic, and we'll also put it up on our website at the point when the help guide is available, and that will cue everybody that it's going to be accessible at that point. So look forward to seeing that distributed out to you.
Great. So I don't see any new questions here for us at the end here. I've answered a few along the way. Not sure whether anybody wants to type in any further questions, but, it's just been a lot of fun, Christine, to be able to work with Alberta on this and to come back to some of these issues that, you know, continue to be important public health issues like pregnancy and preconception and working in new ways that are not just substance-focused, but are really also thinking about issues like trauma and equity and integrating approaches for both women and children.
Yeah, likewise. Yeah. It's been a wonderful experience working with you as well, and I really encourage anybody as you're going through and using these resources, if anything really comes forward as an issue of concern or an issue of consideration, a constructive way of how things can be improved, to let us know. So feel free to email the TRU at albertahealthservices.ca and let us know what you're thinking. You know, we hope that these are really valuable resources that will be useful to everyone, but we always are welcoming people's thoughts and feedback. So just want to put that little plug in.
Mm-hmm. Yeah, great. This is Lorraine. It's been great working on this project, and we too would love any feedback on the guidelines or on any of this material. And I just want to again thank Natalie Hemsing, who's been the research associate on this project and who's done so much digging in the literature to bring it up to date.
And I'd like to put a little shout out for my partner in crime on doing all this work, Gail Foreman. She's a tobacco specialist out of the Central Zone, and she's done an immense amount of work on supporting the development of all these resources, and had actually drawn interest with the TRU to create the Help Guide, which is based on the Tobacco Talk for Two resource that historically had been used in Central Zone. So this is replacing that resource for any public health staff that may be listening. But really appreciate all the work that Gail's done to support it as well.
So, Nancy, do you see any more questions?
Just the one on breastfeeding and cannabis, which I'm just answering, which is basically that, you know, we're still recommending breastfeeding in all cases, and, you know, in a vast vacuum of research to really understand all the issues, you know, and I think that's going to be a really important piece as we go forth.
Yeah.
As we mentioned, there is a resource on the website of Best Start in Ontario that we worked on with them around some of the current evidence around pregnancy, parenting, breastfeeding, et cetera. So people can certainly go there and see that. But, you know, as we said, our bottom line really was caution and to encourage women to think about really, you know, that just because cannabis is being made legal doesn't necessarily mean it's safe, and that, you know, as with tobacco and alcohol and prescription painkillers, it's really recommended that you talk with your healthcare provider about what are the options and ways forward as this research starts to emerge.
Well, thank you, everyone, for listening. This has been really a great opportunity, and we hope that these resources really make a difference to you. So thanks again.